Whether you're looking for answers to specific life questions or seeking to become the best version of you possible, welcome to the Mental Breakdown and Psychreg podcast, where we offer insight, information, and strategies based upon research and years of practice as clinical psychologists. So sit back, have a listen, and get connected with our hosts, Dr. Berney Wilkinson and Dr. Richard Marshall. Welcome back. Today we're going to talk about humanistic therapeutic approaches. We are well on our way through the evolution of therapy from the complete unconscious or subconscious through the sort of the polar opposite of that to behaviorism, which came right after that, to something that bridges the two with cognitive therapies. And now we're going to talk about another one that sort of bridges in some ways with the humanistic approaches.
That's right. This is a more modern look, more modern view. And it's a more complicated view. It is. Because these theories are not as fully developed, and they're a little bit more difficult to get your arms around. There's some, they're embedded in philosophy.
Very meta.
Right. They're embedded in philosophy, and it's not a simple, behaviorism by comparison is a very simple approach. Right. Okay, it's very easy to understand. Very simple approach. This is a little more complicated, a little more philosophical, but we're gonna wade through it despite it being muddy waters.
Right. So some of the founders or some of the people who have sort of fathered this theoretical approach into being, a few of them are names that some people may recognize, but unlike Skinner and Freud and to some extent Beck, while those names are a little bit more widely known, these aren't. We have maybe Kierkegaard is a little bit more known just because that name, once you hear that name, it's like it's hard to not hear it. But some of the others like Buber and Sater are less commonly known. But these guys, again, kind of fathered in this idea that therapy needs to focus on the patient. What they call client-centered therapy. That's one type. Client-centered, but the idea is maximizing the patient. Really sort of allowing this patient to be the center of all the therapeutic decisions and the center of all the processes that are happening to help them along the therapeutic path.
That's right. The idea here is that the individual is faced with this, with their predicament, the predicament of struggle. Okay, that we are all facing the struggle to become. Okay, there are books, philosophy, being is becoming, and this comes out of World War II. A lot of this philosophy comes before and during the World Wars, where we saw these horrible atrocities and we tried to explain them. But basically, it is man's search for meaning and our desire to become all that we can become. So it's sort of based on that philosophy, that philosophical foundation. And so we have relationships with others is one of the issues, but also making choices about we get to choose, and we are responsible for ourselves, and we have to make choices. And we do this within a context, in a context of other people and in our world, whether it's families or work or whatever.
So as you said, in the last podcast, this is sort of another approach that's very consistent to like the dialectical behavioral therapy. It's sort of part of that broader idea that we really need to think about one's position in the world, one's relationships with others. And
one of the curious things about this humanistic approach is that it has its roots in Freud. Not actually Freud, but one of Freud's early disciples was a woman by the name of Karen Horney. And Horney talked about the ideal self versus the real self. And we all have these the authentic self and the inauthentic self. And so we all have this struggle of our public self and our private self.
Right.
And much of this humanistic psychology, humanistic therapy, is reconciling those two and get them as close as you can.
Right.
Because many of us present oneself, but we are somebody quite different.
Right. And I didn't know that you were going to mention that, or else I would have looked it up, because we did a podcast some time ago where we talked about that perspective of
it was a long time ago.
The real self versus the ideal self. Yeah. Right. And yes, it's rooted here in the humanistic theory. So there's a couple of different sort of subtypes of humanistic therapy. And one is, as I mentioned a moment ago, the client-centered therapy. And this sort of works against the idea, and you used the word modern earlier, and this fits very nicely with what we think about with more modern perspectives, and that is, you know what, I'm the therapist, but I'm not the expert. We're going to work together to figure out where we're going to go, because you know more about you than I do. Right. You know more about what you're willing to do and able to do, and what you feel and think about things. And so the client sort of drives the boat. Right. They're the ones that are steering the ship to where we're going.
That's right.
And the therapist is just sort of there to help along the way.
That's right. And the therapist brings to it an unconditional positive regard.
Right.
There's no judging, there's no correcting. You allow the patient to unfold in the therapeutic setting.
Yeah.
But that takes positive regard for the patient. You can't be critical. The patient can't feel you judging or criticizing.
Right.
They have to have the freedom. And again, that's what Freud gave us.
Right.
When you lie on the couch and you said, the therapist sits behind you so that they don't see your reaction. They don't see your judgments of what they're saying. And so, again, we seem to go back to Freud over and over again, but that's the idea here, is that we're not judging you.
Yeah, right.
You're not being judged.
Yeah, exactly. Now, another approach within this family of therapies is called the Gestalt therapy, and what Gestalt means is sort of the whole. Right. It's when you take all these little pieces and you put them all together, and you're looking at the person as a whole, and so we get the organismic holism.
That's
and we're looking at the person as an entirety. And this really works to, in many ways, this is what we think about when we're thinking about sort of, the word is just, it just went out of my head. What was the word? Mindfulness. Mindfulness-based meditation does this because it's focusing on the here and now. What is going on with me now, right now? What am I thinking? What am I feeling? What is happening right now? And this Gestalt therapy really focuses on the here and now.
That's right. And the Gestalt therapists believe that we are always in a process of solving our own problems. Right. Again, we see this client-centered notion in Gestalt therapy as well, that we're always solving our own problems, and we are moving toward resolving this conflict.
Right.
Okay.
Right.
Between who we are and what we are in the world.
Right. Now, the last one that really falls in this category is called existential therapy. And existentialism is where we start really getting into more philosophical things. This is much more philosophical than the other two.
Right.
And so now here we're talking about, one's view of free will, self-determinism, how much control do we have over those things?
But again, we see the client at the center of this. The patient is at the center. They're making decisions. They have free will. They have self-determination.
Yeah.
And so...
What is the meaning of your life? Not what is the meaning of life, but what is the meaning of your life? And existentialism or existential therapy really starts to explore that.
That's right. That's right. We are all struggling.
Right.
And I think that's where we acknowledge that we are all struggling with something or with some things. And so we help guide the patient to resolve that struggle.
Right.
Life is a struggle.
Yeah.
And we work to resolve those struggles.
Yeah. And so this entire therapeutic perspective really focuses on those kinds of issues or those kinds of perspectives. And I want to say that, well, my brain is kind of going to a place where we kind of encapsulate a couple of things from over the past few days, but what else did you have for us first?
One of the things that I found fascinating about the existential approach is that we tend to think of patients as being disordered, of having a disability.
Right.
You know, we're obligated
Right.
to make a diagnosis.
Right.
Okay, we've talked about that on other podcasts. Is because of the way the healthcare system is structured today, you have to make a diagnosis.
Right.
Okay? The existentialist would say, no, these are disorders of living.
Right.
These are life struggles. They're not psychopathology. They're not sociopathy. They're not psychopathy. These are just problems of living. That's what most of us are dealing with.
Right.
And that's where our work has to be done, with problems of living, not solving somebody's mental illness.
Right.
Because most people, in fact, don't have mental illness.
Right.
Even most people who come to see us don't have mental illness. They have problems of living.
Right.
Okay.
And that's where I was going to go, because it's important that we understand that the different therapeutic approaches that we've talked about this week, they're different, sometimes very subtly, sometimes very significantly, and the approach that one uses in any particular setting or any particular circumstance with a patient is going to vary. It's going to be different. It's going to be important as it relates to that patient. You may see 5 different patients all suffering from depression, but your approach may be very different with each of those 5 patients.
6 children with coughs.
Right. Which is a great paper.
Right.
So we have to, it is for that reason that most therapists nowadays are what we call eclectic therapists. And so they're using pieces of different things. There's relatively few that are very, very specialized in a particular thing, unless that's their training. So applied behavior analysts, for example, are very specific strictly to the behavioral perspective. Psychoanalysts are very specific to the psychoanalytic approach. Some people would just do cognitive behavioral therapy. So there are those who are sort of mainlined into one particular perspective, but others are much more eclectic.
But nobody's good at everything.
Correct.
Okay, there are certain things that you and I simply don't do.
Right.
Okay, we don't have the training experience or the background. So our scope of practice is broader than most, but nobody can do it all.
Right.
Okay, and no single therapy solves all problems.
Right.
Okay, cognitive behavioral therapy is wonderful for certain kinds of problems.
Right.
The third issue is there is a therapeutic, no matter what approach you're using, there is a therapeutic relationship that has to be established.
Right.
So you could have the greatest cognitive behavioral therapist in the country, but if you don't establish a therapeutic relationship with that person, it's not going to work. It's not going to work, because you're going to be asked to do things that you're either not going to do or you're not going to do with enthusiasm, and it's not going to work. So be careful of those 3 things.
Right. And I like something else that you said, that many times the things that we've been talking about are for people with or without psychopathology.
Right.
You know, you don't have to have a major depressive disorder to be struggling with dealing with a loss or with a particular life circumstance. You don't have to have generalized anxiety disorder to feel stressed out.
Right.
So sometimes these therapeutic approaches are really designed for the non-pathological patient.
That's right.
You know, and in fact, most of these therapeutic approaches are not at all beneficial with some psychopathology.
That's right.
Schizophrenia, for example. You know, there's not any amount of talk therapy that's going to eliminate hallucinations.
Right.
Now, psychoeducation can help decrease factors that increase the potential of eliciting hallucinations. You know, better sleep, better, things like that. It can improve hygiene and those kinds of things. But no talk therapy is going to take away hallucinations.
Right.
It's just not going to. If a person is in a manic phase, there's not any amount of talk therapy that I can think of that's going to bring the person down from a manic phase.
Right. And
again,
you're certainly not going to do existential or client-centered work with somebody going through a manic phase.
Right.
I mean,
right. So we can't. We have to think about the strengths of these approaches, but we also have to understand the limitations of these approaches. You're not if you have a person who has, let's just say, borderline intellectual ability or even intellectual delays, you're not going to be able to do cognitive behavioral therapy with them. They simply may not or are unlikely to have the level of insight and perspective that's needed for cognitive behavioral therapy or even psychoanalytic therapy.
Right.
For those people in those kinds of situations, you likely need to resort to a behavioral approach.
And again, you make a good point. A person might really need cognitive behavioral therapy, but if they live in a chaotic household, they may not be able to do cognitive behavioral therapy in that setting.
Right.
So it may not be possible.
Right. So it's really important that, if you are struggling with any of these things, with the psychopathology or without a psychopathology, and you're going to talk with a therapist, again, that's where that match is so important, that developing that rapport and making sure that the therapist is able to provide you the skills and perspectives that you need to work through those issues. And if they don't, they need to be, and hopefully will be, honest with you and say, hey, you know what, this isn't really within my wheelhouse. Let me get you to somebody who is much more likely to be able to help you.
Exactly. Right.
So I hope that helps. I hope that helps folks out there. Because sometimes you do have to see a couple of different therapists before you decide on one. Right. You may not be able to, hit a home run with your first attempt. You need to try.
But you need to have confidence in your therapist.
Absolutely.
Because you're going to have to. It's going to be a working relationship, and you need
to trust them.
Right. You have to trust them, and you got to work together. So you need to. If you're uneasy for any reason, it may not work. But you can also be honest with the therapist.
Yeah.
I would welcome somebody coming in and say, I don't like this, or I don't like that, or please explain this, or please explain that. That's good, because that improves the therapeutic relationship.
Yeah, I'll do that with my patients sometimes. I know you do the same, because we've talked about it. That if I feel as though we have reached the maximum of what I can do to help. Right. I'll say, hey, I'm really enjoying working with you. I'm happy to continue if you like, but I'm concerned that as far as how much more I can help, I'm happy to refer you to somebody that I think may be more helpful for you. If you want to keep coming here, then that's perfectly fine, and we'll figure it out. But I think that type of approach is really important, because
Agreed.
There are those therapists out there we recognize who will see you for as long as you want to keep coming to be seen,
or that they
whether they're helpful or not,
or that they convince you that you need to continue seeing them, and caution against that.
Right. So again, not to.
And I think patients should feel free to say, how many times do I need to come here? Right. I think it's an absolutely legitimate question. Right. Do I need to come in every week? How many sessions should I be counting on? How much is this going to cost me? Right. Those are all absolutely legitimate questions. Right. And I welcome those questions from patients. And sometimes we can say, you know what, I think if we just meet a couple of times, I think we'll be okay. There are other times when you may end up with, I'm not sure. Right. Let's meet a couple more times and then reevaluate and then go from there. That's right. Because whether you or not we were able to get a very clear picture during that first. We only have 50 to 55 minutes with a person at a particular time, and so it's hard to know everything in that amount of time. It's not like at the dentist where everything is very. You get those X-rays and it's like, okay, we need to do this, and this. Right. It's a little bit different in psychotherapy. So. Yes. Ours takes a little longer. Yes. To sort out. No drills though, which is of course a benefit. So, all right, we're going to end the week tomorrow talking a little bit about some group therapy, and I think that's going to that's just a very different type of approach that could draw from these others that we talked about, and so we'll go from there. So, all right, good. Until next time, stay happy, stay healthy, don't forget to be afraid.